Good morning. I didn't know if this was going to be a good thing to be early in the morning or it was going to be bad, but I've seen most people looking kind of with it, I guess, this morning. So I'm Jim Bonesuck. I am the Chief Strategy Officer at Aspirion, and thank you all for joining with us. We have an exciting panel, I think, and share some insights with you guys around what they're doing and what they're seeing. Before I do that, a real quick kind of context setting for you guys with Aspirion. Aspirion was, originally it's a services vendor that was started in the complex claims space, specifically MVA and workers' comp, expanded out-of-state Medicaid and VA TRICARE. But in the last several years, we've really expanded, and a major focus of what we do is in the denial space. So denials and aged AR services, and specifically complex clinical denials. And we've got about 190 attorneys currently that work these denials that require clinical validation to pull medical records, craft the case on the appeal to overturn these high-dollar denied cases that the payers are becoming somewhat infamous for right now. And so as we look at the market, we're seeing the trends relative to these payers advancing and investing heavily into the tech, which allows them to deploy rules at a much faster pace than we can necessarily keep up with. So what we've spent our time on, and I know there's a lot of buzz out there, is two things. One, machine learning models specifically to predict our ability to overturn certain denials. So those are, your standard predictive models. In what order should we work those accounts if we're going to deploy resources? But two, more importantly, we acquired a company in Durham, North Carolina last fall called Infinia ML. And Infinia had built 9 PhD data scientists and 12 machine learning engineers out of Duke who built a platform to take unstructured data, structure it in a large language model, and produce a generative output. And what we turned their focus to is working with our attorneys and clinicians to take those unstructured medical records, pull the evidence out, compare it to clinical care guidelines, write the appeal letter, and let our attorneys review it before sending it. So we're doing a lot of work around investing heavily in the actual deployment of AI and ML within our business to produce a better outcome for the work we're doing, quite frankly. And so with that is the context and why is Aspirion speaking about this stuff. I've got with me my Chief AI Officer here and colleague Spencer Alley, so he can spend more time on the technical aspects of what it is. But with that, I want to turn it over to the panel and let them further introduce themselves with their backgrounds, and then we'll get into some of the questions.
Hey, good morning. I am Edna Buffington Price. I am Vice President of Patient Financial Services at Community Health Systems, located in Franklin, Tennessee. I have responsibility for the entire revenue cycle from scheduling all the way through to our 3 shared service centers across the United States. I also am responsibility for the credentialing, our billing support at corporate, our divestitures, conversions, and also our revenue integrity team. So anything related to revenue cycle, pretty much I have responsibility for that at our corporate office.
Hey everyone, Spencer Alley, Chief AI Officer at Aspirion. Been with Aspirion for about 1.5 years, and my background is not in healthcare, it's in applying machine learning to knowledge process automation across industries. So I started off at PwC leading an AI innovation team there for a number of years, worked in venture-backed tech, doing similar work around regulatory compliance manuals and how we automate the extraction of relevant policies and procedures for financial services. So now applying a lot of those same ideas here in healthcare and revenue cycle. We'll talk more about it, but the guiding philosophy for me always is how do we let people do the best work that they can at the highest degree of their license, and how do we automate things that they don't really want to be spending their time on anyway, and that's how we are approaching it at Aspirion. So that's a little bit about me.
Good morning, everybody. I'm Brad Tinnerman. I'm the Senior Vice President of Finance Shared Services at Kaiser Permanente. I've been in healthcare about 30 years. I spent the first third of my career in healthcare consulting. I worked with Jim at Ernst & Young and StockAmp, and then I moved the second third of my career into outsourcing, where I worked R1, worked with a team at Optum to form Optum 360. Then I worked with Jim again at Conifer. And then I got done with being in the vendor space and worked at Banner Health for 7 years running their revenue cycle. I see some familiar faces out there from Banner. And then I got interested in value-based care and the payer side of the business, and Kaiser Permanente had an opportunity for me to join them. So I've been with them over the last 16 months learning the payer and value-based care side while running their revenue cycle.
Morning, everybody. My name's Ted Severson. I'm actually in the process of transitioning. So just in the process of leaving University of Kentucky, King's Daughters, and picking up a position, leadership, doing things a little differently with Eclipse Insights. So very fresh. In fact, this is my second day doing that. So quite the audience, quite the way to start the morning. I've been in healthcare in revenue cycle specifically, for about 25 years now. About 12 as an executive, served with a number of different systems in the Pacific Northwest and Midwest, and all areas of revenue cycle, including managed care contracting, which is quite the subject itself these days. But looking forward to the session this morning. Thanks for the attendance. This looks great.
Let's start back here with Edna here, and we talked about this in the prep, but what are the things you guys are seeing at CHS from a revenue cycle perspective? What are the biggest challenges you're facing right now?
I think for us, there's three main challenges, and I think any provider that's in this room will say staffing is probably the number one. You know, pre-COVID to after COVID, staffing is a lot different than what it was back then. Applicants, what they want, what they remote work, competitive salaries, it's hard to find staff that will stay. One of the main areas that we're seeing this in is in registration and customer service. One of the things that I think that from our challenges is for registration, we expect a lot. They're the first person that patient sees. We expect them to get everything right on the front end. We expect them to collect point of service, to make sure that authorizations are obtained. And then they're one of the lowest paid positions in our company. So I think that's one of the things that we've seen a lot of struggles with. It's just the competitive salaries, where you can go down to Buc-ee's, you can go down to Home Depot. Someone was telling me the other day at a car wash you can make $25 an hour, and we pay $14. So if I was a registrar, I'd be washing all those cars. Customer service is another area that we're having, I think, a struggle with. And that's another thing that we've been looking at, how we can do more AI, how we can do more intelligence to really lower our abandonment rate. So that is something we look at every day and try to move staffing from one shared service to the other. Denials is probably a top priority for us. I mean, you can appeal 5 denials and get 50 more in that day. So there's a lot of things that I think we struggle with, just understanding all the payer guidelines, where you paid it yesterday under this guideline, today you're denying it. So denials has been a major opportunity for us as a challenge to figure out root causes. What do we do to look at what that payer is doing, their behavioral? So I think that's another opportunity. And then pre-auth. Pre-auth, to me, has become a major challenge for all of us. I mean, what we used to could get authorization, you know, you look at your scheduled procedures, you look at what the doctor sent over, we get pre-auth, and in surgery, they add 3 more things. So then you've got to be very proactive to make sure you get the authorizations on that. One of the things that we're seeing now is just like even colonoscopies, where the doctor orders just a general colonoscopy, he takes a biopsy. Well, they're denying because you didn't get an authorization for the biopsy. So with and without contrast, I think those are the main challenges right now from all of us to try to improve our reimbursement and what our associates have to deal with.
Ted, same question to you. Jump down there and then go to Brad.
That was a great response. Thanks, Edna. You took the good ones. But yeah, I think we're all struggling with that. That's a fantastic list. I'll try to go a little bit deeper, maybe. So what I've seen and experienced, especially over the past 7 years, legal resources. We get caught in queues with legal all the time, whether it's over complex claims, whether it's over contract-related issues. Having legal resources that can respond in a timely, effective, and knowledgeable manner, that's a huge problem. It's not one that rolls off the tongue immediately, and not what comes to mind. I mean, it's not authorizations, it's not denials, but it's associated with those. If you don't have the resources to do that, you get lost, you get trapped, you get behind, you write off dollars. So that's been a big one that I've seen over about 7 years or so. Middle management turnover. I think for a lot of years, you had the hypothetical Margaret, who had 38 years of experience as a biller, and almost a hoarder of knowledge, but also kind of that leader for the rest of the folks that were there. Informal leader sometimes a curmudgeon. Those people are leaving, and they've been leaving in droves over the past 5 to 7 years. So what I've seen as a challenge is, well, how do we replace those people? We don't really replace those people. I think you have to leverage your partnerships that are out there. The partners that have and deliver services, but also assist with scheduling meetings and doing follow-up, are just tremendously valuable. They're helping act as almost surrogates for a lot of that middle management turnover that we're seeing in that particular area. Whether it's billing, whether it's collections, whether it's HIM, it's across the board. So it depends on which partner we're talking about, but the best partners, they tend to help fill in that gap because they identify that, because we're losing, quote unquote, Margaret, right? She's gone, that's not there. So we have to rely and lean more, a little bit more on our partners.
Brad, can you kind of compare and contrast Banner to even Kaiser, because it's a bit unique and what you're seeing kind of across the board?
Sure. Yeah, they're different animals, or somewhat different animals, not as much as people may think. Probably three things. I think of the first one, I'll echo what Edna said about staffing. It's probably our biggest issue right now is not only staffing expense, staffing productivity, staffing quality, and that ripples through the entire revenue cycle, front to back. The cost is very high, and our productivity is not where it needs to be. The work from home model has been good and bad. I think you can retain a little bit more, but you're not always retaining the people that you want. So that's number one. So in this conversation around AI, that's definitely a focus of ours, to eliminate where you have the simple portions of staffing that can be done in an automated fashion. The second issue that we have, and I'll say we had this both at Banner and at Kaiser, is host system integration and flows between major components of your technology stack. We're an Epic shop. It's an older Epic stack, and there's a lot of different instances, so getting things done takes a lot of time, whether you're building within the host systems or integrating or layering over the top. A lot of bright ideas that die on the drawing board because of that difficulty integrating with core host systems. The third one, I have a better appreciation for how it should have been dealt with at Banner and it wasn't, and how we're doing a better job at it at Kaiser, and that is building a revenue cycle that has a value-based care approach to it. I don't know if we could see a show of hands of people that work at a health system or work for a health system that has a health plan or an investor in a health plan, hands, people that work in them. And those that might have a risk-adjusted health plan, if you haven't heard of that yet, you're going to, as value-based care becomes a bigger deal. But Kaiser essentially runs three separate revenue cycles. We have a value-based revenue cycle, we have a self-funded insurance revenue cycle, and then we have the typical fee-for-service revenue cycle that most people are aware of. And being able to pivot between those and do all three of those well across many markets with all of this disparate technology makes for a very challenging job, which is mine.
Good answer. And as you're thinking about those challenges that you're seeing there, going to our next question, if I can actually get this thing to work, what approaches are you taking? Brad, we'll stay with you here for a second. What approaches are you guys taking? What are the different things you're doing to address those challenges?
Yeah, I mean, attacking the first two, well, actually all three of them, the automation is a perfect solution for all three of those. And really looking at how you approach the automation in a smart way is what we're taking a deep look at. Simple automation of a particular task. Do you do it within the workflow, or do you do it in an overnight batch type of a process to be able to improve your productivity, reduce your staffing costs, eliminate the variation across systems? So automation in all its many forms is something we take a close look at. As we look at that, you get into the automation space, we really want to make sure what we're talking about from an automation standpoint, because we've all, for 20 years, used things that were keystroke emulation. And now we're moving all the way into things that are true machine learning, where the programs can actually correct themselves. And there's a huge list of things in between. And then where do you apply those different types of automation? Do you apply them, like I said, within the workflow? And do you apply them through batch, where it takes the data and then puts it back into the system? And then as we look at those opportunities to attack those key issues that we have, we then have to look at the type of automation that we're purchasing. Do we build it in-house? Do we buy it? Do we get a subscription service? What's the disaster recovery plan associated with it? So you want to be very careful when you buy something or build something. You have to have maintenance and care and feeding for it. And then the backup, if it goes wrong, what do you do? Because it can actually be your worst nightmare and not your friend very quickly if you don't think through those things. So that's kind of the process we take to look at different types of automation and apply it where we think it best fits.
Are there specific places you guys are applying it now that you could point to? Like, where have you started?
Well, a lot of people tried in the authorization space, and that tend to be a lot more challenging than most people think. Anything that has an if-then to it, when you're like a 95+% chance of the then being the same every time, the back-end workflow is the most typical easy. When you think back, anyone that worked in the back end of a revenue cycle, you had situation response guidelines, and the situation response guidelines were essentially if-then statements. You can take those if-then statements and you can build them into automation. How complicated do you want the automation has to do with how much data you then expose into that automation model. Do you bring the notes in? Do you bring the 835s and 837s in? Do you bring call logs in? And that's where the automation and the whatever level of automation you're looking at can get rather complicated, but also rather effective if you do it well.
Edna, what about you? I know you guys are doing work automating and addressing some of those challenges you spoke of.
Well, from a registration standpoint, what we've started doing, we started this last year, implementing some contactless products in registration. We started out with one market to see how it was going to be receptive in the market. And we were pleasantly surprised, because a lot of our patients in this market, even our older and elderly patients, really didn't want to sit out in the lobby with other patients. And it went over really well. We were able not to fill our vacancies in registration. Point of service increased, patient satisfaction increased. So we started then looking at some other markets to do some contactless. Right now we have pilots with 4 different products so that we can see what is the biggest bang for our buck. We've got one market that it worked really well in. We've got another market that it didn't. But all of that goes back to is actually how do you deploy it? The marketing, how do you work with your physicians? So that is one way that we've looked at the registration side. For customer service, abandonment rates, we've looked at our phone system. What can we automate from automation? So I've got a team that works on that to look to see what we can do, how we can improve it. Like I said, we monitor our abandonment rate every day. Other things from automation, I'm pretty lucky. I've got a team in one of my shared service centers that does a lot of automation for me. So they've been able to we implemented a program within our company that if you have an idea, if you've got somebody that does a manual, repetitive, every day, all day long, you can submit ideas to automate that, and then we prioritize it. So that's one of the things that we've done. The other thing that we've done to reduce denials is a lot of your denials will come from your front end. They don't have the right payer plan. You get a denial, then you get an authorization that wasn't obtained. So we just did some automation to, as a registrar registers, it goes out, looks at your insurance eligibility vendor, what their response was. If it was different, it comes back and actually corrects that account. So when that account goes out and is final billed, you've got the correct payer. So that we've seen a decrease in our denials for incorrect payer. So those are just some of the things that we've done from the automation. We still have a lot of things that we've got up and going right now, but we're always looking at how can we automate things. One of the other things is automating denial, because right now you just can't keep up with it. We've got vendors we partner with to do more complex denials. So we've looked at some of our simpler denials with the CART codes, and we've automated some denial letters that our denial team can use without having to go in and do it manually. We've got another big project that we're looking at from a more complex with an outside vendor, where they will take all of your EHRs, they bring it into one database, which is a very great idea. It will segregate based upon your history and physical, all of your different items and your topics within your EHR. And then they do a lot of analytical work and look at, okay, based upon this denial code, what kind of denial letter do you need? And what is the payer going to require that's going to have to be attached to that letter? So that is something that we're really looking into, I know with several other companies in Nashville, to see what can we automate that our associates are not having to sit there trying to do more complex denial letters and research, where a nurse can get to 10 to 15, that we can automate to get more bang for our buck.
Spencer, on those same lines, I mean, you're seeing couple hundred clients worth of data flow through into the Infinia team, both predictive models that we've developed as well as the automation around extraction of medical records. Can you share with them how you're thinking about prioritizing those types of work, the cases we're doing in the product roadmap as we're thinking about, doing our job to help produce a better outcome for CHS and others?
Yeah, absolutely. So when we think about how we create value for our clients, I think of three ways amongst others. One is, how do we increase yield for our clients? One is, how do we speed up time to cash? And then the third is, how do we actually help our clients be better at denial prevention in the first place? And so our use cases are really designed around those outcomes that we partner with our clients for. So on yield, there are a few ways we approach that. One is what we call selection models, or predictive models that look at which cases are the highest propensity to overturn, and can actually we can put the right resources on the right case at the right time, right? And that's one of the ways that we expand yield for our clients. Another way, both in terms of expanding yield and also accelerating time, is how do we scale the knowledge of our team? So one of the things that we're known for is our expertise, and as Jim said, in our attorneys and our clinicians that we've built over many years. And as denial rates increase and as our business increases, how do we take that level of expertise and apply it more and more at scale? And that's where, with large language models and the kind of advent of machine learning in production use cases like this, we can pull in the right data at the right time, whether it's from medical records, clinical care guidelines, payer policies, managed care contracts, all of these things to bring in that information so that our attorneys and our clinicians can do their work and apply their expertise faster. So that's one way. And then the last thing around denial prevention is looking at the trends. So we know that we're in this kind of system where there's change constantly, and whether that's change happening in why things are being denied, or in the payer policies themselves that get updated, or in the managed care contracts that get updated but maybe don't make it into the system in time. We want to surface those trends and then share them with our clients. So we use predictive models, not just to work the right case at the right time, but also to highlight those trends and how those trends are shifting, because we can use machine learning to identify those patterns in the data, and we can retrain every month and look at how those are changing month to month. So I would say those are kind of our main use cases.
Ted, can you add on to that? Like, what have you, these challenges that you mentioned earlier, what are the things you've seen to address them? I know we work together with you guys, but
Yeah,
what's your perspective?
It's the grace of partnership and having effective partners, and understanding that each of the relationships is different. Great partners adapt to the community. They adapt to the system. They understand, for instance, that if you live in a particular area that's got a lot of retirees that get VA services, then that's a focus. Marketing-wise, community health-wise, great partners participate in local events, right? That's a lot of fun. So it's great to see truly invested partners. To me, that's a really big difference maker that I've seen over the years in gaining those outcomes. Simon Sinek's, who's read The Infinite Game, I would imagine a few people have. If you haven't, you might want to check it out. One of the hazards of that Sinek points out is just the raw focus on numbers, right? Which is by nature what we are kind of groomed for. Is, hey, let's look at the numbers. It's all about the numbers, and in that process, we lose the story. We have to have leaders and analysts in healthcare systems that can effectively tell the story. That's extremely challenging with turnover, with burnout. And again, it's up to our partners to work with us to identify those trends and opportunities to create that narrative. Narrative is something that I talk about a lot in my position to the teams that I work with. We want to understand the narrative. We want to understand what's going on. The numbers don't say that. It's up to us to translate that. And we have to do that effectively. I've seen that as a gap and an opportunity with healthcare systems. But then when there's conversations with great partners that are delivering data, we can interpret those things together and make the right adjustments. So a lot of it's about those relationships for me.
If I could maybe add on to that a little bit, Ted, I think one of the interesting things technologically now that we're seeing with large language models is the ability to marry numbers with text or narrative. So not just looking at what the trends are, but actually why those trends are happening, and going back into whether it's the payer policies or any other source of information, the denial letters, et cetera, actually pull out real insights about why those things are happening, and not just reading the news that they're happening, right? So that, I think that's a transformational moment that we're in now.
Hey, staying on the thread of partnership for a second, and whether you insource, outsource, build, buy, partner, Brad, I know you've got perspectives on that as you've been on both sides and you've done, share with us your kind of unique perspective of how you assess, should we do this in-house at Kaiser? Do we have the capital, the capability, the capacity to do it, or should I look at another alternative?
Yeah, I mean, that's a great question. When we look at an issue that we're trying to solve, we definitely use the buy, build, partner focus for that. Kaiser's a big organization, has a lot of talented individuals that like to and want to try things, and should they is usually the question. We have a large automation team that is good in certain parts of our company. Revenue cycle is pretty unique. Even at Kaiser, it's pretty unique. So we have to be careful about when we build stuff in-house. Buying and partnering, some of our processes and some of the ideas we come up with, we do want partners to kind of design something different that hasn't been done before. So I've done that quite a few times throughout my career. But I will say, in speed to value, buying a service is usually the quickest. And then you can then assess whether you want to then build in-house and then re-insource it later. So I've done that quite a bit, where there's things that I know we could probably get to and get it right eventually, but there's no harm in going ahead and implementing a solution from a third party, and then decide if it's that good and it's that cost effective, then why insource it? Or if you think that it could be, then do that at a later time. So kind of flex through that over time.
All right, so there's a lot of talk about, again, why we're in here, AI, ML, the art of the possible, what we can do with automation beyond RPA and screen emulation that you talked about, Brad. Let's start with Ed, and again, how are you guys at CHS thinking about where do you focus and where are you using kind of AI and ML and these large language models, generative AI?
Well, one of the things that we look at our denial reports, we have an analyst that we get a weekly denial report that shows me every root cause of where every denial comes from. So what we look at is there some quick wins that we could quickly do, some type of an RPA, automation, to eliminate that. So we kind of peel back the onion to see where we can get to. I think your more complex automation, things of that nature, I think that we have to look at a lot of testing. What does it touch? How are we going to implement it? And I think that that's where we look at when it gets to be more complex. Is that something we can build inside with our team? Or is that something that we need to look at an outside vendor to help us with? Because not always do we have the automation team at corporate that knows every little area of everything in our systems. I'll give you a prime example. We started out with something, one of our systems, MedHost, was easy to do. So it's very simple. They were able to program it to do the automation for every step that it needed to take, and it worked perfectly. When we get to Cerner, the automation team that was doing the Cerner side didn't know Cerner as well as they thought they did. So what they did is they thought they had every step covered. The first day it went live, it broke my entire hub. All of my hospitals that were on Cerner was done. So I think that you have to really look at what can you do internally versus what you need an outside vendor to help you with to make sure that you don't break something that you're not aware of when you're doing your testing.
Are there places beyond denials that you guys are currently looking at automation or looking at clinical documentation capture? Are you looking at front end chatbots? Are you what other things are you guys looking at there at CHS?
Yeah, we have a lot of automation. We have one of our big automations that we did a few years back is, everybody had refund clerks that processed nothing but refunds, or you transferred this credit to this debit. So we did some automation with credit stratification and with intelligence to look at what we could automate, transfer into accounts, or we could automate different areas that we only truly got to what needed to be refunded back to a patient and a payer. So that eliminated a number of our refund clerks in each of our shared service centers. So that was a big win. That has worked great. We've got other automation like QA productivity. All of us have remote staff, and you have to monitor them to make sure that they're doing what they're supposed to do. So we did some automation and wrote a program for QA monitoring that we can give feedback to all of our areas. One big automation that we just did, reference labs, is probably large in every hospital. And most of your reference lab, it comes with a diagnosis. So what we did is automated, instead of a coder having to go in and code every one of those counts, it applies that diagnosis automatically. So that's been something that now we're looking at. How can we expand that to different areas within the clinical side that a coder doesn't have to touch that account? So we've got a whole list of things that we're trying to look at to make sure that we get those type of automations up and running. But we've done a lot, I think, internally. And then now we're looking at some things from external of what we could do in more detail.
Ted, jumping back to you, you come from, you've got big multi-state organizations with these two, and then you had a different environment of smaller. Give us your perspective. What were you guys looking at? What was the approach? Where were you automating? How were you thinking about going after it?
Yeah, workforce productivity enhancement is what we were really looking for. So, what we've seen over the past 10 years and a shrinking workforce, the focus was to do replacement, for lack of better terms. Not that we were displacing anyone, but we just couldn't hire anybody. It was pretty tough. It was the wage was not competitive enough, right? And I think a lot of us may find that where what's offered to be in registration, what's offered to be in billing is the same amount that's offered at retail, Walgreens, Costco. But there you have to deal with customers, and a healthcare system, you have to deal with culture, sometimes physician, patients. It's a lot more urgent because it's people's health. It was really workforce augmentation was a lot of what we were looking at for automation. Denial management and prevention, absolutely. That was going to be kind of a boon for us, hopefully. But interestingly enough, when we started to have a lot of those conversations about potential solutions, we started to do partner evaluations. Had a fantastic vendor management partner that I've worked with for about 7 years now. That was kind of a secret in the sauce for us is okay, well, who are we going to work with? How do we vet those vendors and partners? And then how do we get them in place? But how do people's roles and responsibilities change? Operationally speaking, there's a lot of friction surrounding that. And it seems like every few years in revenue cycle, and I'm no surprise probably to anybody in this room, things like access and registration, they either belong with revenue cycle or, nope, now they don't. It goes back and forth a lot. There's a lot of confusion over that. I would say not the level of expertise and competency and leadership. So using AI to identify, hey, who's looking at their work queues? How often are they looking at them? Are they making registration-related errors or not? Is this person a true expert, or are they putting out fires in a clinic, ambulatory area, and they just don't have the bandwidth to follow up on these things? AI helps us identify that and qualify action. So that was another area that we looked at that.
Did you guys in your environment even consider doing it in-house, or was it always, I have to find a partner to help me?
It was finding a partner first and then trying to assimilate it and build it in-house.
Brad, Kaiser's doing a lot of things. What, from an actual AI automation across the organization and in your world, what are you guys working on? What are you doing?
Yeah, I don't think there's a limit of where you can apply it as long as you take a deliberate approach to where you use it and how you're going to use it. First point that we look at is the stability of our host systems and our core technology, because we don't want to build in a place that's under evolution or it's being consolidated or changed. So roadmap of IT is crucially important to look at first. Second, looking at the cost to collect in different parts of the revenue cycle gives you a sense of where you could gain productivity. We'll attack those in areas that are root cause issues or bottlenecks. You can also look at those, so you can start to find a heat map associated with the services that you're running, figure out where to apply those. Next step is, do you do it in workflow, in real time type of an automation where it's kicking off as the data flows, or do you do the overnight approach? And then we already talked about the buy, build, partner. Do I want to build this? Do I want to buy it? Do I want to serve, a subscription on it where they maintain it and keep it up and running? Do they build it and I maintain it and keep it up and running? And what's my disaster recovery if the thing breaks, and for how long? What do I have to have in place to pivot to then make sure that I can pick up that service? So I think if you take a deliberate approach, there's really not a lot of limitations, but you do need to pick your bets, because some areas are just harder to do than others, and start to lay out a roadmap. So I would say there's not any place we're not looking, as long as we go through that process.
Are there ones you're more excited about? Do you think you're going to have a bigger impact?
Well, general revenue cycle is not that exciting, but it's. I mean, working in California union environment, really high salaries. We're targeting the areas that we have the most volume of human touches. So whether that's exciting or not, and let other people decide that. But the areas where we have really, really high cost to collect and high volume, I don't know if most people, I don't know if they look at their transaction volumes and their revenue cycle. We do 110 million encounters a year, which is just a massive amount of volume. And a lot of that is low dollar encounters at physician. We're value-based care, so we're cranking people through that area. So it's just a lot of volume that goes through there, and the cost to collect on that is really, really high. So not exciting, but it's the area you almost fundamentally have to attack to make sure that you can, cost effectively run that revenue cycle.
Yes, I'm going to go to Spencer real quick. Spencer, as we think about the deployment of not just the tech, but the framework that you think about when you think about how do we start to develop this, put it in, and make a lasting change, and you kind of walk everybody through that.
Yeah, so I think, Brad, you touched on a lot of the prioritization framework. The way we think about it very much starts with use cases. So I talked about some of those earlier, but there's a business case that starts with everything before we write a line of code. If you don't choose the right use case, then you might get some learning, but you're ultimately not going to get the results that you're hoping for. So we start with use cases, and then we think a lot about data. So where do we have high quality data at a volume that we need to actually execute against that use case? And then we think about, okay, how does this fit into our platform? At Aspirion, we've invested a lot in technology over the past few years. Over the past couple of years, our technology investment has increased 69% year over year, and that's going to both our core workflow platform, which is called Compass, and then also the Infinia ML acquisition and all of the, we call it DocIQ internally, but it's our kind of intelligence platform that works in parallel to our core workflow system. So those have to work in concert. So platform's a big deal. And then the last is talent. And when we think about talent, we're not just thinking about the data scientists and engineers. We're thinking about how does this actually fit into the day-to-day workflow of our workforce? And who are the people that we're hiring to facilitate that adoption and that change management when we deploy, new solutions for the team. So we take a very product-driven approach, and part of that's just my background in more SaaS product. But we think about our internal users very much like our customers, in the sense of we want to understand what is their day-to-day like, where do they have pain points, and where can we automate those pain points to make their lives easier so that they can scale their expertise across more and more accounts. So that's kind of the high level. When we think about more specific use cases, we can highlight a few, but we are doing a lot of work around how do you extract the right information from medical records using large language models. So in March, we deployed our first kind of iteration of that, where there's a set of predefined questions that get asked for every medical record, and medical records can be hundreds or thousands of pages. So instead of our nurses having to read through all of those, they get a summary that's extracted from those right at the top. And then there's a prompt where they can ask their own questions. So instead of having to scan through and read through, they can just ask whatever they want to ask, and it'll pull out a citation restricting it to the medical record itself. So there's no risk of any kind of hallucinations or anything like that. And then it just accelerates their kind of per account work dramatically and helps them not miss anything. And when we think about adoption of that, it's not just overnight, hey, here's a new tool, start using it. They've been involved in the design of that from the very beginning. So they're helping us understand how they want to use it, how we can make that a successful launch, and then iterating rapidly over time.
And those use cases, so we're seeing trended data across data denials. Can you highlight the top couple that you're focused on?
Yeah, so one of the big ones that we've heard a lot from clients was around DRG downgrades, starting with sepsis is a big one. And if we look at our trends, if this wasn't really a thing, at least for our business in 2019, 2018, and then starting in 2020, that really started to shoot up. And that one, that particular use case was challenging for us as a partner because you're not, the opportunity for kind of winning back that downgrade is a smaller opportunity than if it's fully denied. And so that's, to us, is a ripe use case for automation, because we know that this is a pain point for our clients. We want to help them. And so we've started there with appeal letter automation around DRG downgrades with sepsis in particular. So that's been probably the biggest that has stood out to us, and why we're starting there.
All right, we got 4 minutes left. Quick final thoughts, starting with Edna, and we'll go down the line.
Well, I think his final thoughts, I think you just have to go back to your hospitals, your provider areas, and look at what is the biggest bang for your buck. What do you need to do? What are you struggling with from a staffing perspective? And what you can do with AI and automation to look at what can you implement your quick wins, and then what you want to do long term. And make sure you have a strategy plan. And like you said, sometimes it's working with an outside vendor until you can get it done internally. But I think just understanding exactly where your opportunities are and your challenges.
Spencer?
Yeah, I mean, I think for me, and I'm biased obviously given my background, but we're already living in an AI world, right? I mean, your phones, your cars, your computers, everything that we're consuming media-wise, the advertisements that get served to you, all of those are already driven by machine learning and AI. So I think, for us as a vendor, we feel that it's our duty to make that investment on behalf of our clients to make sure that we can stay ahead of the game. And we know the payer side already has a big lead on technology investment. So how do we start to close that gap? But I would just encourage everyone to think about what is their strategy, because I think you do need to have one, whether it's in this industry or any of them. That's just the world we live in now.
Brad?
We talked about a lot of the structured approach, but definitely get tied to the hip with your IT partners to make sure you understand their roadmap. We didn't touch on the definitions of automation because there's so many different types. I remember early on we were all very confused by what is machine learning and automation and keystroke, and there's probably 8 different terms that are used and literally defining those, so when your team is talking, they understand exactly what kind of automation they're using or proposing, and the ramifications of that type of automation. How complicated is it, and where should it be used, whether it's in workflow or in your overnight batch type process. So having a roadmap, having a strategy, and having an organized approach that's lined up with your IT group, I don't think there's a limit in this space as long as you take the time to sit down and map it out.
Dad?
A bit more of the same. It is time to develop a strategy surrounding this officially. I think that people have been deliberating that the past 3 to 5 years. Now is the time. The technology is maturing. It's coming to fruition. There are a lot of effective solutions out there and great partners. What makes a difference? One of the things that's always made a difference, aside from the team on the provider side, for me, what has made the biggest difference is great account management with partners has made ultimately the difference. Having partners that listen and adapt and personalize the solution, that's fantastic. That's the best of the best. Bringing wisdom to the table, bringing an ear to the table, making recommendations that even sometimes go outside of their proficiencies just in terms of what they're seeing elsewhere. And also, a great, effective vendor management partner has made a huge difference as well.
Well, and Brad, you made a point about what is AI ML, what are the definitions? So slight plug, but we did a 4-part webinar series. Spencer did a very nice job. And the first one that's on our website explaining the actual technology and what it is, breaking it down. So look for that. I want to thank you guys for the prep and being here and partnering and doing all the things you do and sharing your insights with this audience. It's been awesome. So thank you very much for your time, and thank you all for coming.
Thanks, everyone.